a 33-year-old male presented with lower back pain. I am showing you sagittal stir, coronal stir, and axial T2 weighted spinal MRI scans. Describe the findings.
Let me just study this for a second. Right. The sagittal stir spinal image demonstrates smooth, posterior scalloping of multiple vertebral bodies, most prominently at the T11, T12, and L2 levels. There is an associated mild thoracic scoliosis present on the coronal scan. At the T10 level on the coronal steer image, a well-defined right-sided hyperintense lesion is seen projecting laterally from the spinal canal through the neural foramen. This lesion matches CSF signal on all sequences, indicating a lateral thoracic meningocele. The axial T2 weighted scan demonstrates a second lateral meningocele on the left side at a similar level, and multiple cutaneous hyperintense subcutaneous nodules are noted along the back.
I am showing you magnified views of the posterior vertebral scalloping and the lateral thoracic meningocele. What is the diagnosis, and what are the classic spinal features of this condition?
The clinical and imaging features are diagnostic of neurofibromatosis type 1, also known as von Recklinghausen disease. The classical features in the spine include lateral thoracic meningocele, posterior vertebral scalloping secondary, and dumbbell-shaped neurofibromas occupying the neural foramina. Additional features include kyphosis, scoliosis, hypoplasia of the pedicles, transverse or spinous processes, and enlargement of the intervertebral foramina. The presence of multiple cutaneous and subcutaneous neurofibromas, visible on sagittal imaging, is a helpful diagnostic clue.
How do you radiologically differentiate a lateral thoracic meningocele from a dumbbell-shaped neurofibroma on MRI?
On MRI, a lateral meningocele contains simple cerebrospinal fluid, showing low T1 signal, high T2 or steer signal, and no internal solid tissue or enhancement. In contrast, a neurofibroma is a solid tumor that enhances avidly following gadolinium contrast administration. On T2-weighted MRI, neurofibromas often display a characteristic target sign, consisting of a hyperintense periphery and a hypointense central fibrous core. Furthermore, a meningocele is directly continuous with the subarachnoid space, which can be demonstrated on thin, sagittal, or coronal slices.
What other abdominal or systemic vascular findings should you search for when neurofibromatosis type 1 is suspected?
In patients with suspected neurofibromatosis type 1, it is important to evaluate the retroperitoneum for adrenal masses and renal vascular abnormalities. Specifically, one should look for pheochromocytomas, which can occur bilaterally or ectopically in these patients. Renal artery stenosis, due to fibromuscular dysplasia, or neurofibromatosis vasculopathy should be ruled out, particularly if there is renal asymmetry or hypertension. Gastrointestinal stromal tumors, duodenal somatostatinomas, and plexiform neurofibromas are other abdominal associations.
What is the risk of malignant transformation in these neurofibromas, and how would you manage this patient as a radiologist?
The risk of malignant transformation of benign neurofibromas into malignant peripheral nerve sheath tumors is approximately 2 to 3%. A rapid rate of growth, new onset of localized pain, or progressive neurological deficits should be thoroughly investigated with PET-CT or biopsy. As a radiologist, I would recommend a baseline MRI of the entire spine to document the extent of dural ectasia, meningoceles, and plexiform neurofibromas. I would also recommend screening the abdomen with CT or MRI to rule out pheochromocytoma and renal artery stenosis, and refer the patient to neurogenetics for clinical management.